I'm going to turn the next session over to Dr. Mark Johnson, who will moderate.
Okay, our next speaker is Dr. Lau, who is a pediatrician. She got her medical degree in Columbia. That's not Columbia University, but the country of Columbia. She's worked as a general practitioner for the underserved regions of Columbia, and she worked there implementing new healthcare programs for children. She then did her pediatric training at Morehouse School of Medicine in Atlanta, Georgia. She's a northern representative for the American Academy of Pediatrics Utah chapter. Has an emphasis in childhood obesity. She does community outreach programs and health fairs in northern Utah. She's also the mother of a heart patient, so she has a special interest in children with special needs. She's fluent in both Spanish and English. And she'll be joined today by Wewer, who received her master's degree in food and nutrition from the University of Utah, and then a BS in dietetics from Indiana University in Pennsylvania. She currently works at Ogden Regional Medical Center as an outpatient dietitian. She's an instructor at the University of Utah, and she co-teaches a wilderness nutrition course, and they will both be speaking to us about the consequences of childhood obesity.
Well, good afternoon, everyone. Let me just get familiar with this first. Pointer working? Oh, yeah. Guess it's not. Okay. We'll see. Okay. Well, we're going to talk about the consequences of childhood obesity and how can we get prepared today as physicians to treat this growing problem. We see it every day. It's a problem worldwide. Some countries don't have much of an issue like we have it in the United States, but it's still a big issue. In Utah, according to the health department, about 60% of adults, Utahns, has either overweight or obesity. 1 out of 5 children in elementary school age and high school age has obesity or overweight. This is a good question. It is okay for babies to be obese. This is a picture of my baby actually, but well, he's not obese actually, not anymore. There's several studies that have shown that early introduction of solid food in babies correlate with obesity. A recent study done at Children's Hospital in Boston, Massachusetts, shows that babies that were introduced with solid food before the 4 months of life, they have increase on their BMI after 3 years of age, and they were obese babies. The introduction of solid food was associated with those babies that were fed with formula, and it was not associated with babies that were exclusively breastfed, no matter if the introduction of solid food happens before 4 months of life, which is still showing breastfeeding as a good thing, a good protecting factor too. Among infants who were never breastfed, or those who were stopped breastfeeding before the age of month, they showed an increase of 6-fold on odds of obesity at the age of 3 years of age. There's other studies showing that kids that had a BMI higher than a 95th percentile by 24 months of life, those kids are going to have obesity by the age of 12 years of age. In the past 30 years, the occurrence of overweight and obesity has doubled. It's now estimated that about 1 out of 5 children in the United States is overweight. And also, the bigger kids are becoming bigger every day. We're seeing in preschoolers and easily in adolescents. the prevalence of overweight is especially higher among certain populations like African American, Hispanic, and Native American, where the prevalence goes between 35 and 40%, with a BMI above 85%, and 85 percentile. Sorry. Also, like I mentioned, while the big kid is becoming heavier, the results of childhood overweight is regard the most common prevalent childhood or kids nutritional problems that we see in the United States. And one of the most common problems that we see as pediatrician, and believe it or not, is most common that ear infections. This graph it shows how the obesity is growing in the ages between 6 and 19 years of age. The prevalence has gone almost reaching 20%, and this is showing from 1963 to 2000. Okay, obese children are most likely to become obese as adults. One study shows that approximately 80% of children who were obese between the ages of 10 and 15 years of age, at the age of 25 years, they were obese. Other studies show that 25% that more than 50% of children that were obese passing the age of 8 years, they were more likely to become obese with severe morbid obesity as adults. Consequences of childhood obesity. Well, the consequences that we see here are short-term consequences and long-term consequences of the effects of overweight. We have negative psychological consequences and also health consequences. One cross-sectional study using national data, they studied children between the ages of in the grades between 7th grade and 12th grade in the years of 1994 and 1995. They collected a sample of 4,700, and all those kids, they were significantly overweight, and they noticed that the majority of those kids were suffering of depression, poor self-esteem, and they have severe impairment socially and school impairment also. Another study that also kind of gathered same amount of on the sample, and this was done at Duke University, shows that children between ages of 15 and 17 years of age were suffering of severe depression due to their weight. Those children also had problems at home with their parents, and they have a lot of separation anxiety, which is something that we'll see more in young kids. And there also were significant impact on the employment of the parents, which they cannot correlate if it was related to the obesity of the kids or the depression of the kids. But we can tell that this is a factor that affects the whole family. Another interesting study done in a rural area in the Smoky Mountains shows that young kids with obesity were more likely to become with an oppositional defiant disorder, and also show signs of depression too. This study also showed that boys were more likely to engage on behaviors like eating and binging, and girls were more likely to get involved in frequent dieting. Excuse me. The negative health consequences, I think those are the problems that we never thought that we will see in a pediatric patient, and I see it in my practice. In metabolic syndrome, acanthosis nigricans, type 2 diabetes, hypertension, this was never in the pediatric board. Now, questions for that. The high total LDL, high cholesterol and high LDL cholesterol, also high levels of triglycerides, low LDL cholesterol, sleep apnea is one of the major complaints too. And also, I get it so frequently, the parents bringing the patient, well, my kid is being diagnosed with ADHD, or he has ADHD, attention deficit hyperactivity disorder, and this is a kid that he might have a sleep apnea, and he might, just with a little bit of weight loss, he can correct the symptoms, and there's no need to put this kid on a stimulant medicine or any other ADHD type of medicine. Just weight loss will help. Early puberty, fat gets accumulated and then transformed in hormones, and that's the reason why some obese people are told and they can develop some breasts. And I get it frequently, like, we all got big bones, or we are coming from big family, and so when parents are not eager to accept that their kids had some problems, so the whole family have it. Blount disease, that is the bow leg problem. Slip-to-capital femoral epiphysis is a fracture through the growth plate of the head of the femur, and is for the femur holding, carrying that heavy load. The non-alcoholic steatohepatitis, or is the infiltration of fat in the liver that causing that inflammation in the liver. And interesting enough is to see how the liver enzymes correct after 3 months that this kid is committed on a weight loss program. Okay, this is the problem. Why so many physicians or providers don't feel interested to treat obesity or follow obesity, because it doesn't get reimbursed, because it takes so much time, because the people don't, the parents or family don't get committed on that. Well, and those are the things that we have to take advantage in how to code for precisely obesity, because obesity is a multifactorial condition. We can take plenty of time counseling this patient and instructing this patient what to do, and therefore one of the things that the American Academy of Pediatric Division of Health and Quality Improvement advise how to code is to use a time as a key element of coding for this. So many of the times this type of visit gets reimbursed better than just an office visit. Some of the insurance some insurance don't want to pay it if you just want to bill for obesity code as itself, because Medicaid in 2004 decide to not recognize obesity as an illness. The other thing is, if you have anybody that has referred a patient, anybody different to a family member that refer a patient to you due to condition as obesity or any of the comorbidities, you can code as a consultant, and all you need to do is send a note to the person that has referred that patient to you, and the note can be just a copy of your office visit, and that count as a consultant code. As a consulting visit. And again, some of the AP task force for obesity has shown that those codes get reimbursed better. Other thing that the AP recommend is coding instead for obesity, coding for one of the comorbidities and of obesity, like acanthosis nigricans, hypertriglyceridemia, hyperinsulinemia, metabolic syndrome, sleep apnea, the ones that I mentioned before, depression, anxiety, all those things, they can be coded as obesity, and always the obesity diagnosis has to be tagged along. There's other B codes that it can be attached to it, but they don't recommend to leave V codes just along with obesity. They always recommend to put a comorbidity there because the comorbidities for obesity, they are recognized as billable diagnosis. Okay, so the treatment has, I'm not going to tell you anything different. It's just diet, exercise, change the lifestyle, regular physical activity for the entire family. It's not just for the patient. I have so many parents that said to the patient, you see, the doctor's telling you have to move more. No, it's not just for the patient. It's the entire family. And there's several ways how the family needs to, they can exercise. It's just, clean the dishes after dinner, clean the table, move around, go up and down the stairs, vacuum around, and be interested to know how many calories we can just burn doing simple things like vacuuming, make you burn 100 calories, mopping the floor 100 calories, walking at a pace of 2 miles per hour, it make you burn around 80 calories, and that's great. And for a kid, it doesn't have to be a significant activity. They usually are active, but families need to set a good example. And this is a website where the whole family can track their activity, and at the end they kind of earn medals, and it's kind of interesting and fun for the whole family. Of course, nutrition is an important part, and it's not to decrease or do a diet. In kids, it doesn't work, at least after we reach 8 years of age, and then after 8 years of age, definitely they are morbid obese. But before 8 years of age, is try to eat healthy and teach them how to make good decisions, how to choose healthy food. And my friend Katie will talk more about that part. Screen time. This is a problem in kids. Studies show that kids eat more while watching TV, and especially commercials. Commercials are a big influence in kids for toys and food. So limit the amount of screen time for your kids, 2 hours maximum daily. Otherwise, they'll send them to play. That's what they need to be doing. Put this slash. This is a slide that shows the latest study in the pediatric journal. It was published in March this year. This is a study that shows long-term results of an obesity program in an ethnically diverse pediatric population. So what they did was that they got 280 kids that were obese, and they divide them in 2 different groups. One that were going to be monitored at a regular clinic, but they were seen only every 6 months, and that's it. The other group were going to an intervention type of clinic, the same doctor setting clinic, but they were being seen twice a week for the first 6 months. After the second 6 months, they were being seen twice a month, and then after 12 months, they were not seen at all. So what it shows is that this column in here is the intervention group. What it shows is that it was very significant. Anything negative is positive for that. The BMI decreased, and it was also compared between groups. This is the comparison between groups. Was statistical significant between groups after 6 months and 12 months. So what it tells us is it's good, but what is more, what I found it more fantastic is with the cholesterol levels in the intervention group, it decreased almost to be significant, just for a little point there. And 12 months and 24 months after this, 12 months that they didn't have any intervention, any follow-up, they keep on going down. That is in cholesterol level. Same with fasting glucose and with the insulin level. Keep on going down. So what it tells us is that no matter what, it is worth it to help those kids and follow up those kids and teach them how to control their weight and how to maintain their weight, and just keep on following us in our practice, even if it's just to say, hey, how are you doing? What do you think about your weight? You think that you're gaining? You think that you're losing? Or what do you think that you eat today? Did you think that you eat good veggies? Not like I asked one kid, I asked him, do you think that you eat veggies? Yes, I did. I got my ketchup today. So I think we can make a big significant change in the kid's mind if we see them regular in our office, and not only the kid, the family. And this is a nice picture of Ben Lomond. I make it there after a few blisters, but I make it. It was good. All right, Katie, your turn. Thank you.
Have a couple of props that I want to get out before we start. Okay. My name's Katie Wewer. I'm a dietitian at Ogden Regional. I do mostly outpatient nutrition there with children and also with adults. I see a lot of people with diabetes as well. And today we're going to talk about some practical nutrition tips. I'm hoping that by the time you leave, you have a couple of new ideas that you can share with your clients or patients or family members or maybe yourself as well when we talk about nutrition. And so these are some of the things that I think are very practical and very simple things that kids can follow. It works for kids. It works for adults. It works for anyone. So first we're going to talk about the weight loss goals for childhood obesity and for children, some of the common nutrition offenders, and then I have a list of some foods. And this is a stoplight approach, as we'll see, slow, go, and whoa foods. And this is very fun for kids, and they can look at the charts and see which foods they should have more of and less of. A couple simple ways to measure portion control. The plate method is another practical tip that we use in portion control and balanced healthy eating. A couple of label reading tips for your patients, a healthy snack list, and some resources as well. So those are the things we're going to talk about today. First, the weight loss goals. In little children, most of the time we don't really want to focus on weight loss. We want to focus on healthy eating. How can your kids be eating healthier? How can they be including more fruits and vegetables, whole grains, and less of the sodas and the cheese, mozzarella cheese sticks and fish sticks and all those fried foods that kids typically tend to migrate towards. So for the most part, with younger kids, we want to maintain their weight and let them grow into their weight as they gain in height. For those that have a BMI over the 95th percentile, at the very most 1 pound a month of weight loss, but really we don't want weight loss. We want them to just grow into their weight. Same with kids from ages 6 to 11. Weight maintenance is the goal. If they're over the 99th percentile, gradual weight loss is okay, but just not a lot, because they're still going to be growing in their height. When you get to age 12 to 18, there's a slow rate of weight loss is what we're looking for, of no more than 2 pounds per week. And I personally think that that's a little much. That's what I recommend my adults to lose, 1 or 2 pounds a week, and that's a lot to lose in a week. But those are the guidelines from the American Dietetic Association Pediatric Nutrition Care Manual. So as kids get older, we do encourage weight loss if they are morbidly obese, and that's okay for them. There's a website you're probably all pretty familiar with, mypyramid.gov, and on it lists the general guidelines for calorie ranges for different ages. And this depends on their activity. If you have athletes that you're working with or that you're seeing, of course they're going to need more of the higher range of the calories. And then those that are sedentary are going to need towards the lower end. One thing that I want to point out, you may or may not know, is 1 pound is equivalent to 3,500 calories. So in order to lose 1 pound, you need to create an energy deficit of 3,500 calories. And we like to do that through both diet and exercise. If you were to break that down into a week, that's about 500 calories per day that you want to create a deficit of. So that's why I said when you're trying to lose 2 pounds a week, and in some of the shows that are out and they're losing 5 and 10 pounds, that's a huge, huge energy deficit that they're creating. And with kids, it's harder to do that. And again, we like to focus more on healthy eating, portion control, not a diet necessarily. On the other hand, to gain a pound, you need to intake 3,500 calories more than what you expend. And so we think about exercising, running for an hour, you burn 500 calories. Well, how many cookies can you eat that equivalent to 500 calories? So you have to kind of put it into perspective there. That's why both diet and exercise is really important for both kids and for adults. So some of the most common things that I see as I counsel patients, again, both kids and adults, are consuming too much soda, sweetened beverages, and juices. And one thing that really is eye-opening for my clients, I have a few bottles that I sit on my desk, and I'll just show you here. I've got a Pepsi, a Mountain Dew, and a juice. This is 100% juice, no added sugar to it, and it shows you the amount of sugar that's in that juice, the amount of sugar that's in that Mountain Dew, or in the Pepsi. And really, the amount of sugar and carbohydrates that are in these three are very similar if the serving sizes were the same. Of course, I have different sizes here, so they're a little bit different. But even with juices, there's quite a few, 12 teaspoons of sugar in this bottle here. And so when I have this out, it's a really good eye-opener for folks. And it might be one of the things that you can do in your practice. Get some clear Pepsi bottles. You look at the total carbohydrates. This says 27 grams. Of course, there's 2.5 servings in here. So you have to multiply that by 2.5, and you get 68 grams of carbohydrate or sugar. And there's 4 calories per gram. So you can do that math and figure out how much sugar is needed in these bottles to show them. And it's a huge eye-opener. Let me tell you, people are always like, oh my goodness, I had no idea. And so that's one practical tip. If you just had a bottle or two in your office or somewhere that you can grab and show your patients, it can really help them out because they get to see the amount of sugar. Some of the other nutrition offenders are, of course, your high-fat foods, your fried foods, chips, candies, goodies, a lot of filler foods, that sort of thing. Another thing I see is not eating enough fruits and vegetables. Obviously, how many of you get 5 a day, 5 fruits and vegetables a day? It's hard, even as practitioners, we know what we should do, but it's hard to actually do it. And so, excuse me. So that's another place of emphasis that I like to share with my clients. Skipping breakfast is another. How many of you had breakfast this morning? Some, yeah, good. Breakfast jumpstarts your metabolism. It helps your energy levels, your blood glucose levels go. Another common offender, large portion sizes. And this, I think, is really interesting, too. One of the strategies that I teach my clients is portion control using smaller plates and bowls. So I have a couple different size bowls here. We've got the small one, the medium, and the large. And I'm not kidding when I see kids tell me, I ask them, which size bowl is closest to yours at home? Kids will tell me they have this huge bowl. Well, how much do you fill it up with? And then I have these beans that I show them. And so this is a 2-cup serving of beans, and they'll put the 2-cup in, and then they'll put the 1 cup. Because, right, we want to fill up the bowls. We want to get the most out of our food. Well, a serving size for cereal in general is about a cup. It's about the size of a woman's fist. Well, you put a cup in this big bowl, and you're going to feel like you're deprived. You put a cup in the middle-sized bowl, you're doing a little bit better, but using smaller plates and bowls for kids and adults, again, you feel like you're going to get more food. You feel like you can fill up your plate. You feel like you can fill up your bowl, and you're getting more for the, you're just getting more. And mentally, it's really helpful when you're trying to do portion control. Another common offender is eating out of the bag or the box. You sit down by the computer, you sit down at the TV with the whole box or the whole bag. And so one thing that I stress and emphasize is if you're going to have the chips or you're going to have the crackers or whatever, look at the serving size, and if it's 15 chips, count out 15 chips, put the bag away, put it back in the cover, put your chips in your bowl, and then enjoy them, and sit there and eat them and enjoy them, and try not to eat when you're doing something else. But if you happen to do that, enjoy those foods, eat them slowly, and stick to the serving size that's on the box. How about this, the clean your plate mentality? You've all probably grown up with that mentality or going back for seconds unnecessarily. And these are a few things that I see a lot with our kids and adults, like I said. And one thought that I share with my clients a lot is the food is going to go to waste somewhere. It's either going to go to waste in the trash can or onto your waste. Which waste would you rather it go to? So these are a couple of questions that I ask my child patients and their families. What are they eating for breakfast? First of all, I want to make sure they're eating breakfast, but then what is it? Are they having Pop-Tarts or some high carbohydrate, like super high sugary food for breakfast? Or are they having a well-balanced breakfast with a low sugar, higher fiber cereal? And there's actually a lot out there that are tasty, that kids will enjoy and will like if they have the opportunity to try them. They might not be as colorful as the Fruit Loops and the Tricks, but they do taste good. Eating every 3 to 4 hours for children is really important too. And so if there's not an afternoon snack, I encourage them to have something healthy and planned. Again, not eating out of the bag or the box of foods, but to have a healthy snack planned. And at the end of the presentation, I have a few creative, healthy snacks for kids. What are you drinking during the day? Again, calories in beverages add up so quickly, and it's a big problem for kids. Even Gatorades and iced teas and lemonades, all those have a lot of carbohydrates and sugars and extra calories that we don't really need. How often are you eating fruits and vegetables? And I encourage kids to try to eat a fruit or a vegetable with each meal. If they can pick it out at school, to have at least one fruit or vegetable for breakfast, lunch, snack, and dinner. And then how physically active. So those are some questions that you can ask your patients that will give you a lot of good feedback. So this is the what's called the traffic light approach, the slow, the go, and the whoa foods. This chart we have available in the back, but it's also available online, and I put the reference here so you can download it. It's really, really helpful, and I'm not going to go through all of the foods, but in general we have the green light, the yellow light, and the red light foods. Green, they can have almost any time. They're low in fat, low in added sugar, they're nutrient dense, have some fiber in there. The yellow foods are okay foods, and then the red foods are those that have a lot of added fat or added sugar. They're really calorie dense, low in nutrients, not so good for you, and they should be limited to once in a while or special occasions. And when I talk with my clients, I like to get an idea of where they are right now and go from there. If they're eating junk foods 3 or 4 times a day, well, then I say, okay, once or twice a day is where we want to start with you. And if they're having these foods, once a day, then I say, well, let's cut it back to every other day. And so I try to be practical with recommendations, because if it's not something that's practical, they're not going to do it. They're not going to stick with it. So these are a few examples, and I'm just going to let you guys read through them, of some green foods. More green foods. And again, these are both in your CD and your presentation and in the back. Some of the yellow foods. So here we have the 100% juice. Again, juice is more nutritious than soda, but as far as calories and carbohydrates and sugars go, they're about the same. More slow foods. And then your red foods or your woe foods, the ones that should be limited. French fries. All right. So one way that I encourage folks to monitor their portions is by using your hand. So everyone lift up their hand for me. We've got a fist here. Okay, so one fist for kids and adults, and it doesn't matter, and what I usually recommend is going by your fist size, so it's proportionate to your body. One fist for rice, spaghetti, pasta, potatoes, cereals. That's the amount that is a proper serving size. 2 fists for non-starchy vegetables, for your greens, for your broccoli, cauliflower, stir-fried vegetables. 2 fists. The size of your palm for lean protein. 1 or 2 thumb tips for fats. The fist for milk or yogurt, again, that's about 6 or 8 ounces, and then a fist for fruit, too. And when I'm talking with kids, this is one that you always have your hand with you, and for kids, it's something that they can look at and do, and so then I'll test them. How many fists for vegetables? How many fists for cereals? And they really seem to like that, and it's a simple way for portion control for anyone. There are some other items. A deck of cards is about 3 ounces of protein. A small baked potato is the size of a computer mouse. A teaspoon is the size of a dice. Personally, I like the hand thing because it's right there with you and it's a little easier. But these are some other things that might relate better to some people. Another way for portion control and balanced eating is called the plate method, where you have a plate, and half of your plate is from vegetables. A quarter of your plate is from starches, particularly the whole grains and starchy vegetables, and then a quarter of your plate from meat or protein, your lean sources of protein. And I have this nice plate here to use as a prop when I'm talking with my clients. But you can simply take a paper plate, draw a line in half and then in a quarter, and show your patients how their plate should be dispersed with the different foods. We also have a sample of this plate in the back too, in the packet that we'll give to you so that you can use. You're welcome to photocopy that as well. But it has a plate and how you should rearrange your plate. And for a lot of people, at least that I see, with the pasta and the rice, and again, even kids and adults, they have 2 or 3 cups. You want to fill that bowl with rice and pasta, right? Well, when you take a look at the plate method, you're rearranging it so that the rice and the pasta take up a quarter of your plate. It's not the main meal anymore. It's the side dish. The poultry and the meat is the side dish. It doesn't take up half of your plate, but the vegetables. That's where we want to emphasize is including more vegetables and fruits. And then on the side is fruit and milk or yogurt, if desired. And then going back to using the smaller plate is important. My pyramid, again, this is the new Wewer food guide pyramid. On this website, mypyramid.gov/kids, there's a whole kids section on here. So you can use this, again, for adults, for kids. They break it down into preschoolers, age groupers, teens, that you can go in and get some ideas and some tips on how much fruit should a 13-year-old be eating, how much fruit should a 10-year-old be eating, or grains or that sort of thing. So it breaks it down. This particular one is based off of a 2,000-calorie diet, which, as we saw earlier, there's a wide range of calorie needs for individuals. All right, and then we have the nutrition facts label. This is another thing that I try to emphasize with kids and their parents as well. The main things that we're going to look at are the serving size. How many of you would guess that there's 4 servings in this container here? So all of the numbers that are on the back, you think, 110 calories. I'll work out 110 calories worth. Well, no, it's 440 calories in this Mountain Dew, which, we looked at earlier, a 500 calorie deficit a day. You cut out one of these that you're drinking a day, and you're probably going to lose almost a pound a week right there. Or if it's in addition, you'll gain a pound a week. So always look at the serving size and emphasize that with your patients. And then the next thing is the calories. And it's helpful to know about how many calories a person needs, and in general it's around 2,000. But like I said, that varies dramatically. Everything's based off of 2,000 calories. For fats, we want to keep the saturated and the trans fats as low as possible. And the fiber is another thing that I really try to emphasize because it's really helpful for weight management along with all the other things, the lowering cholesterol, blood sugars, digestion, moving things around in your body, elimination. So fiber is really important. And for kids, kids need their age plus 5 grams of fiber per day. So if they're 7 years old, 7 plus 5 is 12 grams of fiber. That's the amount that kids need up until they reach about 25 grams a day is the recommendation for women. 30 to 38 is for men, for adults. All right, so the things to keep low, the things to look for 2 or 3 grams of fiber per serving. Limit sugar to less than 10 grams. And then here's the little conversion. 4 grams of sugar is equivalent to 1 teaspoon of sugar. Here are a few ideas for some healthy snacks for kids. Peeling a banana and dipping it in yogurt and rolling it in cereal, then you freeze it. Smoothies are a good thing, as long as there's not a lot of added sugar, or no added sugar, actually. If it's just fruit and yogurt blended together, that's good. Toast a whole grain waffle with some yogurt and some peaches. So, again, just a few ideas for you here. In the back, we also have this chart that we have developed, and it's really helpful. It's a little tracker for kids to use, or adults, again, to use. It gives you recommendations on how much fruits, vegetables, whole grains, dairy, and water, and then it allows them to put little check marks on here. Again, that's available for you guys. You can photocopy it and give it to your patients and clients to use, and they can copy it as well. The other thing we put on there is some exercise goals for each day of the week. At least 60 minutes of exercise a day, and limit any kind of screen time to 2 hours at the max. School lunch nutrition. There's a lot of controversy, I guess, about the nutrition programs here. But the thing that I want you guys to know is that online on the different websites for the schools, the nutrition information is available that you can go on and look up the nutrition information for the different meals that schools provide, or the parents can as well. If you have some concerned parents, you can let them know that this is available on the school or the district websites. And then if you can encourage their parents to pack a good, healthy, balanced lunch 2 or 3 times a week, that's 2 or 3 times less that they might be having fish sticks and pizza and burgers. The other thing that I like to emphasize, like Dr. Lau said, is the family. It's a family thing. Parents are role models. Parents, the kids will watch their parents. They'll do what their parents say. If there's always a soda nearby, mom or dad, there's going to be a soda nearby the children as well. So the parents need to act as good role models, take responsibility for their kids' choices. And with food choices, kids like choices, right? They like to have a variety of things to choose from. But if all those choices are healthy, then it's a win-win situation. The kids get to choose something that they want, and it's a healthy choice. when all the choices that are available are not so healthy, then they're going to choose their favorite, and it's not so good for you. So you want to offer a couple of healthy choices. And then encourage cooking, gardening, any kind of family time around food preparation and meals. And then I have a few money-saving tips as well. Buying in bulk, buying things on sale, seasonal produce and freezing it. You know how much money you can save if you don't buy sodas or if you don't buy chips and you don't buy things? I had a client not too long ago that said her grocery bill actually went down by about $60 because she didn't buy any of the junk that she normally bought. And she bought fruits and vegetables on top of that. So she still saved money. A lot of people think fruits and vegetables are more expensive, and you can balance it out. You know, what's worth it to you? Is it if you can save money buying those healthier foods, and not if you can save money by not buying the unhealthy foods and using that towards your fruits and vegetables, it can make a big difference. Of course, there's coupons and gardening in the backyard. And then these are a few kitchen staples. These are some really inexpensive foods that should be part of most everyone's kitchens, I think. And then we have some resources here, too, for you, the Women, Infants, and Children's, the SNAP program, which is food stamps. And then the Utah State University's expanded food and nutrition education program. This is a really neat program. I put the website on here, but they have free nutrition classes. And someone's told me that they will come into your house and they will take what you have in your cupboards and they will help you make a meal out of it. So if all a patient has is there's a low-income patient and they have some bread and some rice and some beans, they'll take the food that they have and they'll put them together and make a good, healthy, nutritious meal out of those foods. So it's a really good program that's available. And then here are a few websites that I've talked about. All right. I think that's all for me. Does anyone have any questions for either of us? Yeah, yeah. What was the name of that again? Utah Partnership for Healthy Weight. Okay. Okay, that'll be wonderful. Okay. Great, thanks. Oh boy. Artificial sweeteners in children. Artificial sweeteners in children is what she asked. And I'm not a fan of artificial sweeteners at all for children or for adults, honestly, but we do know that the sugar in beverages, we know what that does. It increases blood sugar, particularly with people with diabetes or who are at risk for diabetes. And then the non-nutritive sweeteners, they don't raise blood sugars. And so from that perspective, it's better. But my recommendation for most people is moderation, one thing a day, one drink a day if you have to. But I don't like to see kids with diet sodas and diet things either. They're approved by the FDA. They're not. No, it's a sweetener that's used in place of sugar to sweeten food. So they're approved. They're fine to use. I just don't know that there's a lot of studies on children and the use, especially a high use of those sweeteners.
Children with ADHD, they should not be consuming that one too. The artificial sweeteners, they made them more hyper, and it's not a good thing either for them.
Mm-hmm. Yeah. Yes.
I have a question about the use of some of the newer approved medications for weight loss in adolescents, and electrolyte diet,
That's a great question, and that's the reason why I didn't put any of those medicines in there, because the studies have shown that the medicine, the ones that have been more studied in adolescents is metformin, and it truly does not help with the weight loss. It helps with maintain the weight if the patient is committed to exercise and losing the weight. There's other medicine that have been approved, but there's not in kids. It's not nothing that it will be drug-wise related for that.
How about for your patients, your patients that you're planning to see,
I don't do it. I have, to be honest with you, I have a patient that this year I put her on metformin because she is 310 pounds and she's 13 years old and she's trying to. So I put her on that one, but I said to her, let's try it for 3 months and see if that helps. But the study shows that once you discontinue the medicine, it's not much a significant change. So it's truly not recommended to use it.
Metformin or medication?
The topiramate is not it's what it does is it just makes you have a bad taste and decrease the appetite on the kids. But in kids, you don't want to make them think that you're taking a pill to lose their weight, right? You want to change their life. You want to help them to improve their life, because that's a problem that we have sometimes in our society. Oh, I can fix this with a pill or get it in the supermarket. No, we need to change that. So if we can limit it to put that in the minds of the kids, saying, hey, I can prescribe you this, at least there is a problem, a health issue that definitely we need to work it out, and there need to be more specialists. I mean, there need to be a specialist involved. Fine, this kid needs to be on medicine, but I don't recommend that. And the studies clearly show that let's go diet, exercise, and change on the lifestyle on those kids first before we committed to do any drugs, any medication. Any other questions? Right here.
So, on the obese children, how often do you get blood work? And if you get blood work, what do you
I usually do it in the first visit, just to get a baseline, and then 3 months from if they're truly committed losing weight, and then after that, every 6 months, just make sure that everything's fine. Liver enzymes, that's one of the things. The lipid panel, that's the other thing that I check. In the insulin level, and then then if we get to a level that is fine, then all what we do is continue checking the the blood pressure.
The physical activity. We have that in the back, actually. As part of the packet, we have a little brochure that has different places that people can exercise and just different resources. It's in the back with that packet. Good. Yeah, sure. Any others? Go ahead.
On the artificial sweeteners, I was wondering, Doctor, if you run into it wasn't directly on obesity. About 7 years ago or so, there was a prospective study, 10,000 people watched for 10 years. They finally published it, and they were, it wasn't that long ago, about 5 years ago. Anyway, they were looking for which food groups, a high protein, a low protein, a high carbohydrate, etc., which ones were related to obesity, and they were a little stunned when by a factor of 3 times higher, aspartame was the highest correlation for the onset of obesity. I'm sorry, the onset of diabetes. But since those two are linked a bit, I'm wondering if there's
directly with the artificial sweetener? No.
Artificial sweetener was 3 times higher than any other food thing they could do. They could
Right.
drink. And it was at 1 drink per day or higher. And it's been replicated twice since then, but none of them had the 10,000 people.
Right. Right.
You know, so the first study is actually the most interesting one.
Interesting.
For the long period, so many people.
Right.
I always felt like it wasn't Pepsi Cola or Coca-Cola. We'd be hearing more about that study than the ones that came after it.
Right. No, I've seen that.
Counterintuitively, the regularly sweetened ones were not related to the onset of diabetes, which was counterintuitive. But that's different than, of course, somebody who already had diabetes. Talk about the initiation or bringing it on over time.
Right. I don't see anything. No.
It's easy to track it down if check quality is partnering.
Right.
And they'll track it down. The study's out there. You can track it. Let's get publicized.
That's interesting.
About 5 years old.
Thank you.
Yes, in the back.
So if you have that child who's over the 90th percentile, and you're trying to either maintain that weight as they grow or help them lose weight, how much intervention on your part does it take to be successful in your experience?
Oh, that's a great question. A lot of frustration. It depends on the family. It depends what I see if the family is committed, and usually the child wants it. So what I try to do is see the kids monthly for the first 3 months in my office, and I do a first set of labs, and I like to do the labs and show the numbers to the family and show them how bad it can be in the numbers, and then I send my patient to my friend Katie, and then from there we start communicating how that goes. And usually every month I see them in the office, and then if they're committed, I see that they're fine, then I go to every 3 months, every 6 months. And like I said, the first visits are the ones that I take more time, because there's not only just obesity there's more issues. Depression is number one on the majority of those kids when they're there. They're older than 8 years of age, and some of them, that is when I go and treat them. Once I treat the depression, then their weight improves. Or there's other issues like breathing issues or other things that I can take care of that. But yeah, usually the first 3 months are the ones that I try to be more on top of all that. Yes.
There is a doctor in San Diego who has shown a strong correlation between adult obesity and adverse childhood events such as very difficult divorces or abuse. Has this been looked at in children with obesity, and is this something we should be looking at in our obese adolescents and children and get into psychological, psychiatric?
I believe it completely. For what I mentioned, so many of our obese patients, they have psychological problems, psychological diseases that never has been looked at it. And sometimes just with a simple questions, had you ever been sad? Right? Describe to me what is sad. What did you do when you're sad? One thing they said, I just sit down and eat. Something interesting that one of my patients told me was it was a boy. I asked him, why do you eat a lot? Why do you feel like eating? And he said to me, it helped me to calm my pain. And so those are the things that sometimes we just don't take the time to ask kids, because we just think, oh, well, this is a chubby boy that just likes to eat. But that might not be the part, and I totally believe it. If you're not growing in a healthy environment and healthy, stable environment, this is the way how the kid can go around. Yeah. Any other questions?
Last question.
Yes.
So if you're checking lipid panels and hypertension, how aggressively are you checking their caring for their other metabolic risk factors? And so what guidelines are you following for pediatrics?
Yeah, whenever I have,
cardiologist down at Primary Children's Hospital was recommended that if the kids were going out of well, for kids it's different to the adults, the levels of cholesterol and lipid panel. So it was recommended that once it will be going above the normal range for kids, it needs to be seen because they've been seeing coronary problems already in kids. So my job is not going to try to do an anti-lipid medicine or things like that, but what I try to do is see if with the diet and exercise program and interventions that can get remodified in 3 months. If this kid is not improving the laboratory test in 3 months, then I will need to refer to cardiology for further evaluation if they have some continue having problems with the lipid problem. So is there a specific name for the guidelines for Cristina and or exactly with guidelines for adults?
Well, to treat children, you mean to treat the hyperlipidemia in children? Yes, well, there's not a particular name, but you will be able to find it in the American Heart Association. They have a particular table how they start to treat with statins is the number 1 medicine recommended for children whenever they are with an elevated level. But again, once it's detected as pediatricians, then it's recommended to send it directly to cardiologists because of that issue, that coronary problems that they can develop. And they usually ended up putting this patient. They do the same thing. They put in diet and exercise, but they monitor more frequently and then put them on statins.
Thank you very much. That was an excellent talk.